Hi guys, I am recording this audio for you because I am not able to present in class today. And also I'm going to upload this to the YouTube channel so people can go back and use it to review for the exam. So let's get started. So for this chapter, you're going to want to review the anatomy and physiology that you already know about, but pay special attention to some things that are different with pediatrics. And one of the major differences is that children are growing. I've said that throughout the course, but in endocrine, it's even more so important to remember that how the endocrine affects the child's growth and development and linear growth. So certain endocrine problems can lead to stunted growth. So pay extra special attention to those, and also be able to identify the functions of important hormones, signs and symptoms that there might be a problem developing with the endocrine system. Identify especially endocrine problems that can cause stunted growth. Be able to prioritize your nursing care for a child that has an endocrine disorder. Be able to intervene if there's an educational need with the family, or if a patient's deteriorating, be able to recognize those signs and symptoms. And also, I would look into, especially in this chapter, steroids that we use for some endocrine disorders. That you'll want to review what you know about lifelong corticosteroid treatment, how that affects the child's growth and development. We'll talk about that more. And then distinguishing between type 1 and type 2. So you guys might have learned quite a bit about type 2 already, but generally type 1 diabetes is something that we emphasize more in pediatrics because it's more common with pediatric patients. Also, be able to plan care for a child that has been born with an inherited disorder, including if they need genetic counseling or that kind of thing. So hormones that are released in the body don't all come from endocrine organs. That's one thing that I like students to know. For example, fat cells in your body make estrogen. That's in males and females, and some amount of hormones are made in different tissues of your bodies. But for endocrine system, we generally focus more on specific organs, but just do remember that any tissue in your body that makes a hormone is technically also considered endocrine. But in specific, the job of a hormone is to affect the cellular activity inside a target cell. So it can have to do with the timing of the hormone being released. Some hormones are released throughout the day, whereas some are released more at night. Some are released continuously throughout the 24-hour period. And the job of hormones are to regulate the energy and metabolism of cells, maintain homeostasis. Hormones are responsible for growth and linear growth and development of secondary sexual characteristics. Hormones are responsible for moods and emotions. Hormones are involved in our bone health. And then also hormones are involved in maintaining our water and electrolyte balance, and also coordinating some of the complex functions of our body. Some of the secondary sexual characteristics that you'll need to know in this chapter are known as the Tanner stage. This is the scale we use to determine how advanced a child is in their sexual development as far as secondary characteristics. And just to remind yourself what the Tanner stages are, they include things like body odor, breast development, development of adipose tissue in girls around the hips. In boys, um, it can be muscular development, penis enlargement. It can be change in the voice and the character of the voice. So remind yourself of all those different Tanner stages. Also, you'll want to focus in on insulin. We'll talk about that more in depth when we get to diabetes. And then also remember stress hormones, adrenal glands, that play a role in the body's response to stress. The main organs that we're talking about are going to be the pineal gland, the thyroid gland, the adrenal gland, which sits on top of the kidneys, the ovaries and testes, the pancreas, thymus, and hypothalamus. So puberty is initiated in children by an increase in production of GnRH, or gonadotropin-releasing hormone, from the hypothalamus in the brain. This in turn stimulates the anterior pituitary gland to release luteinizing hormone and follicular stimulating hormone. When these two hormones are released into the bloodstream in response to the gonadotropin-releasing hormone, they travel to the testes in boys or ovaries in females and stimulate their developmental function. In boys, luteinizing hormone produces a release of testosterone. In females, you have follicular stimulating hormone stimulating the ovarian follicles to produce estrogen. This becomes a feedback inhibition, or a negative feedback loop. So as the testosterone or estrogen levels increase in the bloodstream, they provide negative feedback to the hypothalamus and the anterior pituitary gland, and this inhibits further release of the gonadotropin-releasing hormone, the luteinizing hormone, and the follicular stimulating hormone. And in this way, you have a precise regulation of growth. So just enough gets released to produce changes, and then they reach a certain level, and then they stop temporarily. And this goes on until the child becomes fully developed. As the gonads mature and hormones reach their optimum levels, the feedback mechanism helps maintain that hormonal balance. And this testosterone and estrogen are the primary reasons that you start to have secondary sexual characteristics developing. So an increase of body hair, changes in voice, development of breast tissue in females, and penis enlargement in boys. So overall, the feedback mechanism during puberty helps the child reach a coordinated development of secondary sexual characteristics as well. So before the onset of puberty, if you'll remember back to Freud, we have the latency phase, and this is an important phase in pediatric development because the child is able to focus on learning that's going to be needed to for the child to be able to mature enough intellectually to become fully functional in adulthood. So the purpose of the latency phase is to provide maximum learning opportunity during those years. The sex hormones increase when puberty begins, and so the average onset of puberty is 9 in girls and 11 in boys. Menstruation for most girls is between 11 and 13 when it starts, and this generally signals sexual maturity in females. It's important to remember that besides the pituitary gland for proper growth and maturation. The child needs not just growth hormone, but the thyroid, the adrenal glands, and the gonads to all be producing hormones the way that they should. And for proper metabolic function, the child needs ADH or antidiuretic hormone, parathyroid, and insulin function to be working properly. If there's a direct disruption in any of these systems, growth and development can be interrupted, and metabolic function can also be interrupted. These are some of the labs or diagnostics that are pertinent for this chapter that you need to know. For example, you're probably all familiar with the HbA1c, which is also called glycosylated hemoglobin. It's a measure of how much glucose is stuck to hemoglobin, and when you have glucose that's attached to a hemoglobin, it's called glycosylated. And that glucose stays there on that hemoglobin until that hemoglobin cell dies. And so it provides a good 3-month window of how well the sugar has been controlled, because if your levels of glucose are going down, then the excessive amounts of hemoglobin that are glycosylated will die and not be detectable anymore. If they're going up, then the numbers will increase, and it's for the life of the glucose, so that's about 3 months. So that's very important to determine the long-term control of the patient's glucose for the last 3-month period. But some other important labs that you would need to know, so bone age is very important for children. When it's basically accomplished with a series of x-rays, and what we're looking at is to determine the amount of epiphyseal plate growth that the child still has remaining, and that gives us a good idea of the age. And if the bone is closed, we can then determine bone age a little bit further by if the bone is decalcifying. That can also be an important measure of bone age. In children, you definitely need to have those epiphyseal plates open, and that's one way that we can get some advance notice if a child's growth is going to be stunted. We can also do thyroid antibodies, of course, T3, T4, and those to check thyroid function. One important one, you should circle it on this slide, is the newborn metabolic screening. That is accomplished by a heel stick on the baby before they even go home from the hospital at birth. So generally they do it between 1 and 3 days after birth. They poke the baby's heel, and then they take some drops of blood from the baby and put those on a piece of paper, basically. I can show some pictures in the next slide. That paper gets sent off for analysis by a lab, and they can determine if there's about 50 different potential genetic metabolic problems that the child could have. So all kids are required to get this. It's very difficult to opt out, and that's because if the child doesn't get it, for example, PKU, by the time they would start to have symptoms of PKU, the child would have brain damage. It would be too late to intervene to help. And so the idea is to get these things diagnosed before their symptoms so that they can treat and prevent brain damage. So like I said, there's about 50 disorders that they now test for that. So we don't call it the PKU test anymore. We call it the metabolic screening, but it's the same thing. It's basically the heel stick of the baby on day 2 or 3 of birth, and then they redo it 14 days later. So it's a series of 2 heel sticks that the child gets. We can also check thyroid function by doing the thyroid radioactive iodine uptake scan. That would be related to some thyroid problems. adrenal suppression test, ACTH, is a test that we might do. So familiarize yourself especially with the PKU and the hemoglobin tests for this and chapter and the bone age. So one of the important disorders that we're talking about in pediatrics first is hypopituitarianism, which is when the child doesn't make enough growth hormone, and the pituitary gland then fails to stimulate linear growth. Also cell reproduction and regeneration. So this deficiency results in the child to have stunted linear growth, and also developmental delays are possible, affecting their overall, not just linear growth, but mental health. So hypopituitarianism can be caused by a lot of underlying problems. So that it can be caused by a tumor or a mass. These can be cancerous or non-cancerous growths inside the cranium. And these press on the pituitary gland or disrupt the production of the pituitary gland, and the treatment for that would be hopefully removal of that mass. It depends if there's long-term damage. That will depend on when it was picked up on, when it was noticed, and if we were able to remove the tumor or not. Other causes of hypopituitarianism can be head trauma, and so especially boys are at high risk for this. If you have head trauma that's near the base of the skull, where the pituitary gland is located, you can disrupt the blood flow to the pituitary gland, causing hypopituitarianism, and that would damage and impair hormone secretion. You can also have an infectious process. So, for example, meningitis, the bacteria can cause pus pockets to form near the pituitary gland, and if that crosses over in the blood-brain barrier there, it can damage the pituitary gland there. So it can also be damaged by bleeding. So if you have a stroke, which is less common in children, but it is possible with some other disorders. So severe bleeding can compress the brain there and can damage the pituitary gland. Or you can have a genetic problem that leads to a structural problem with the pituitary gland. So that one would be something you would see more at birth, rather than something that occurred later on. So the hallmark sign of hypopituitarianism is delayed growth. So and this is why it's so important that you be able to plot out the child's growth on the CDC growth chart. So anytime you see the child not meeting that initial line that they're on, so say that they started off on the 25th percentile for height, they should stay on the 25th percentile for height throughout their childhood. If you see them start to decelerate in their growth, which would be defined as less than 5 centimeters of growth per year, or a drop of as much as 5% or more on the growth chart, then that would need to be referred to assess for whether or not there's damage to the pituitary gland. Other signs are delayed and absent puberty. So you can have girls that have a lack of breast development that can be common, or boys that have a lack of development of facial hair. That would be a sign, although I wouldn't call it a hallmark sign, because lots of kids have less breast tissue in girls or boys that have delay in facial hair. But fatigue, weakness, those are also common with growth hormone deficiency. You'll see less muscle mass in boys and girls too. Weight gain is possible due to disruptions in the metabolism. So remember that growth hormone also affects the metabolic functions. And then hypoglycemia is common with this disorder. So you'll see shakiness, dizziness, and fainting. And then delayed or irregular menstruation in girls is an important sign to be aware of. So when you start to have Tanner stages, development of breast tissue or changes in voice and whatnot, in girls, they should start their period within a year or two of that. And if they don't, then that needs to be referred. Visual changes can also occur, especially blurred vision, double vision, or loss of peripheral vision, and this is often a sign of pressure inside the skull related to a space-occupying lesion or possibly, a cancerous or non-cancerous tumor, but also bleeding or something causing pressure there. You could have headaches, and that would be another sign of a tumor or a mass inside the brain, and especially in the front of the head. This would a hallmark sign of a space-occupying lesion is sudden onset of vomiting, especially early in the morning on waking. And then another sign is increased sensitivity to cold. So children with hypopituitarianism usually feel excessively cold due to a lack of thyroid hormone, which is important in regulating body temperature. And a sign in boys is also micropenis. So those are important signs to be on the lookout for. So once you've identified that a child has hypopituitarianism, the main treatment is going to be hormone replacement. So the child's going to need growth hormone, thyroid hormone, adrenal hormones, possibly sex hormones to normalize their hormone levels and promote healthy growth and development. Regular checking is going to be very important of their growth to make sure that once they're taking these medications that they're being compliant with the medications, and also that the medication's doing what it's supposed to do. So you have to continually track the growth velocity using that growth chart and check hormone levels as far as frequent checkups for overall health. Sometimes there's a dosage adjustment that's necessary if one hormone isn't doing enough on its own. Nutritional support is very important for growth and development. Children need adequate nutrients to support growth, protein and iron and calcium and all these things. And then psychosocial support, because there is often a psychological component to children adjusting if they have a delay in growth or impaired or stunted growth. That can affect the psychological state of the child. Also, being that the underlying cause could be a tumor, there might be some surgical intervention required. So if they do a CT of the head and they find a space-occupying lesion, they'll be scheduled for a surgery to remove that. And then, of course, the nurse's number one job, one of the most important things we do, is we provide education to the family and the patient, and then also emotional support. So a very important part of nursing is that emotional support piece. Now, nursing considerations that we think about with children are self-esteem is the main one. And if you think about it, growth hormone deficiency would cause more of a self-esteem problem probably for males than for females, because the societal expectation of males is often that they be tall, which is unfortunate for them if the parents can't afford to treat that. It can and studies have shown that it affects lifelong earning potential and a lot of different emotional side effects with that. For girls, we're concerned that they're going to have, and boys too, that they're going to be treated as though that they're younger because they're smaller. They can be bullied, teased, and so one of the things we want to do is support a healthy self-esteem, but also body acceptance, because if there's nothing we can do to stop the growth from being stunted, then we want to teach them to have a positive self-image despite their limitations. So that's an important thing. You can also have hyperpituitarianism, and this is when children grow, they don't stop growing, and so they can grow to be 7-8 feet tall before the epiphyseal plates close, and in some rare instances, maybe even as much as 9 feet has been recorded. And this, another word for this is acromegaly, because it's not just the long bones that grow, but you have growth in the jaw, and it can change the person's appearance significantly. So boys are less likely to be treated for this because, like I said, societal expectations are that boys should be tall. And so the parents might not feel a need to treat the child for this. Whereas a girl, they're more likely to get treated for this because societal expectations are that the girl will be shorter in society. Bone age is important in this determining or diagnosing this condition, because you see the child should be decelerating in their growth, but in this case they are not. And so we send them for x-rays and we can see if the epiphyseal plates are not closing the way they should. They may need to give some medications to force the closure of the epiphyseal plates to stop the growth. And so sometimes this can be caused by a tumor. In this case, rather than the tumor pressing on and inhibiting the pituitary gland, in this case the tumor would be arising from the pituitary gland itself and making more pituitary hormone than it should. So in this case, it's instead of inhibiting the pituitary gland, it's actually overproducing. And so they would have to resect the gland in that case, and then they would need the opposite. They would need to have hormone replacement for healthy balance of the hormones that are stopped after the resection of the tumor. So precocious puberty affects about 1 in 5,000 children, and it's 10 times more likely in girls than boys. And this is defined as the onset of puberty in children less than 8 for girls and 9 for boys. For Hispanic girls, the age is less than 7 because they're genetically predisposed to going into puberty sooner. So the way that you can detect that is, again, going over your Tanner stages, and if you have the Tanner stages, the appearance of breast tissue, arm, leg, or pubic hair, voice changes, body odor in menses in girls, and penile enlargement in boys, moodiness, acne, all of those are part of the Tanner stages, and that needs to be followed up if the child is less than those ages. It has been becoming so common, though, that they're actually thinking of lowering the age to 7 all around. So remember that the causes of these can be, again, a head trauma and cranial radiation secondary to a space-occupying lesion in the brain, or they can be idiopathic, which means that we don't know what causes it. And here it says it's more frequent in boys than girls, whereas up above it says on this slide that it's more common in girls. The reason for that is it's more common in boys secondary to head traumas. So in all other cases, it's more common in girls, but if the underlying cause is head trauma, that's more likely in boys. And it's also the incidence is increased related to obesity, certain ethnicities, genetics, predispositions, Psychological stress can actually trigger precocious puberty. So, like in third world countries, if you go to where they have a lot of food insecurity or they're very poor, the psychological stress can trigger premature puberty in that age group to so that the child matures faster so that they can deal with their situation. Or it could be environmental causes, and sometimes they'll never know what the underlying cause was. So in this case, they would do based on an assessment findings, they would do a luteinizing hormone and follicular stimulating hormone assessment. Lab draw, they would do testosterone and estrogen testing, gonadotropin releasing hormone testing. They would send possibly the child for x-rays to determine bone age. And they can also do CTs and MRIs to look for tumors in the brain. The goal of treatment here is to stop or reverse the development of the secondary sexual characteristics. And also to maximize the adult height. So gonadotropin releasing hormone agonists reduce the production of puberty hormones in the body, and also we want to identify the underlying cause. So just because we notice the child has precocious puberty type symptoms doesn't mean we can rule out, for example, that there's a space occupying lesion in there. So they more than likely will check all those things. Now, like I said, some parents don't see the need to treat any of these problems because the treatment costs money and there's societal expectations. So it's very important to provide proper education to the family about why it's important to get the child treated. And with precocious puberty, one of our biggest concerns for girls in particular is that they have a much higher rate of early sexual involvement. They have, if they look older, then they get treated older. And so that would be something to prevent. You would not want to have your 7-year-old girl becoming sexually active. Even though that they might physically look old enough to do that. So we want to promote them spending more time with their same sex peer group and their same age peer group in that case. Other things that we are concerned about in girls is the longer you have breast tissue, the higher your risk for breast cancer is. And so by having breast tissue, say 2 to 3 years younger than your peers, makes you at higher risk than your peers, relatively speaking. So we do have a concern about breast cancer with that. So another problem that is possible in the pediatric population is SIADH, or syndrome of inappropriate antidiuretic hormone. This is caused when the child makes too much ADH. Another name for that hormone is vasopressin. And this is what normally regulates the fluid status in the body. So what happens is when you have an elevated ADH, the kidneys reabsorb too much of the water back into the bloodstream. So the urine that goes out is more concentrated, and you have dilutional hyponatremia in the bloodstream. This causes some neurological symptoms associated with hyponatremia. So you have headache, confusion, seizures, and sometimes coma and death are also possible with this. Also, usually when you have hyponatremia, your body tells you to stop drinking. But in this case, the child's thirst mechanism is still intact, and so the child still wants to drink even though that they have excessive hyponatremia and excessive fluid already in the body. So the normal compensatory mechanisms of the body are not working properly. So overall, the effect of SIADH is to disrupt the normal fluid mechanisms in the body that cause you to either urinate more or or retained fluid, that it's not working properly, leading to some life-threatening complications. So with SIADH in your pediatric population, it's important to recognize the condition quickly and treat the condition, but also to identify the underlying cause quickly. And that is because the first problem that's going to be life-threatening is the hyponatremia and the fluid imbalance. But if it's caused by a tumor, that could also be life-threatening if that's not recognized and treated right away too. So remember, all those things go together in SIADH. So as far as recognizing SIADH, you would want to be on the lookout for signs of water toxicity, which would be the most immediately life-threatening in the child. So you would have edema, jugular vein distension, lung crackles, lethargy, confusion, headaches, seizures, coma, and hopefully you catch it before death occurs. The hyponatremia is you can see that on a blood test. Basically a BMP would detect that. We could also detect changes in the serum osmolality and the urine osmolality. So it would be, so the sodium would be low in the blood serum, but it would be high in the urine, because remember, those are two different spaces. And then you would see a decreased BUN. The treatment for SIADH for children would be to restrict fluids and then to give diuretics to get rid of the excess fluid. And then we give demeclocycline to block the action of ADH. And that medication, I would want you to take a minute to look up for the test to make sure you know a little bit about it. It's very important that the child has that medication with them or handy. They can't skip or miss any doses. And then also we can give hypertonic IV fluids to try and correct this situation. Also, we want to take daily weights. And then one of the teachings that you need to know about demeclocycline is that it has some nephrotoxic side effects. So that's why we want to follow the BUN levels on the child. And the child has to wear a medic alert bracelet when they have this disorder, because if they're ever found down, one of the things that they automatically do when they find people unconscious is they give fluid boluses, which would be entirely inappropriate in this child's case. Diabetes insipidus is another important one that we need to go over. One of the big mistakes I think students make with diabetes insipidus is they think that it is related to diabetes type 1 and type 2, and they think it has something to do with the pancreas. So one of the main things I need you to know about diabetes insipidus is that it has nothing whatsoever to do with the pancreas. It was named diabetes insipidus back before doctors understood the function of the pancreas. And so it was just called that because it was related to the fluid status changes that you see with patients that have diabetes. So to the extent where they're actually looking at renaming it to something else now. So what I want you to know is that, first of all, the 3 P's that you see with diabetes, the polyphagia, polyuria, and polydipsia, we don't see polyphagia with this disorder, and we don't see hyperglycemia with this disorder. We do see polydipsia. So what you have in diabetes insipidus is a loss of water conservation. You have frequent urination, excessive urination due to low ADH, and that's the cardinal sign of this disorder. Like I said, it has nothing whatsoever to do with sugar or with the pancreas. So you can have central diabetes insipidus, or you can have neurogenic diabetes insipidus. So I know in the adult population, you have a lecture on this where it's generally treated as something that's temporary, but that's not the case in a lot of pediatric cases. So try to keep this lecture separate from the other lecture you're getting. But 20 to 50% of pediatric cases are idiopathic, so they don't know what's causing it. And it can be related to pituitary damage. It could be related to surgical damage, again, trauma such as head trauma or infections. Nephrogenic is more dangerous than central. And in this case, you have renal tubule unresponsiveness to ADH. And this is generally genetic. And it's not as common as the acquired type in pediatric cases, but the presentation is more severe and life-threatening. So remember that kids that have a genetic predisposition, this is going to be a long-term treatment, and it's not going to go away. So make sure when you're educating the families that this is not temporary or reversible. Other causes of diabetes insipidus, it can be caused by drug toxicity, so you can have drug-induced diabetes insipidus. And so then the treatment hopefully would be to remove that drug that's causing the problem. So if the problem with diabetes insipidus is that you have an inability to concentrate urine, then that's the test. So normally if you and I are deprived of water, we will not be able to make urine. Our urine output will go down and down and down. So what they do to test for this is called a fluid deprivation test, and a person that has this their urine will not production will not go down the way it would in a regular person until there's no fluid left. And so the child will become excessively dehydrated, and you'll see severe symptoms of that before they stop making urine. So the onset of this can be a sudden onset or a delayed onset. Desmopressin acetate is the drug that we use to treat this, and this is another case where the child would need a med alert bracelet, and also they have to have constant access to water in a bathroom, especially like school, if they're going on school trips, or say you're going out to an away game on a bus or something. This would be a case where the child can't really ride the bus with everyone else because the bus would have to stop for them to use the bathroom every hour. You can teach the family workarounds, like in this kind of case, like a parent would drive the child wherever they were going instead of taking the bus to the away games and whatnot. But they need to have that med alert bracelet because, again, this is a situation where if the child was found down, they would need to know what is going on with the child. And children have this tendency to want to keep these kind of disorders secret, so they don't want to wear a med alert bracelet. They need to be told that they have to wear it. So hypothyroidism is another disorder we need to talk about real quickly. Hypothyroidism in children can be either acquired or congenital. Congenital is something that we need to recognize quickly before damage occurs. So I want to talk about this. The picture that I have on this slide is of a child that has congenital hypothyroidism. And the signs here can be easy to miss. If you look at this picture, the child has an enlarged tongue, and this baby cannot close their mouth, and that's a big sign. And also the way the eyes look. So most babies are born with bright, wide open eyes, and they look around and they're curious. about their surroundings. But a child with congenital hypothyroidism would have a sleepy, kind of dull look to the eye, and they would be lethargic and not really looking around with curiosity. They'd be hypotonic in their muscles. So this baby has the classic signs of hypothyroidism. This occurs in about 1 out of 4,000 births, and in this case, the gland is either missing completely or it can be ectopic, which means it's born outside of the place where it's supposed to be, and in that case, it's not functioning properly. What it does is TSH secretion is not enough to stimulate thyroid function, and sometimes it's brought on by the mother taking PTU. PTU is a drug that is given for moms that have hyperthyroidism. Hyperthyroidism, it depends on the severity. The mom, if they find out that they're pregnant, they generally will go off of PTU. However, it depends on their symptoms. If they're too severe, they may need PTU to survive, in which case the mom would probably still keep taking the medication, knowing the risk to the child, and then we would just treat the child if they were born with this. So that is an underlying risk factor. But most of the time when you have a baby with this, it's hard to catch because the child maybe doesn't have such a prominent tongue, but they do look sleepy and lethargic, which is not that unusual. A lot of babies are sleepy and lethargic after birth. The difference here would be the child's also got cold intolerance, so their temperature would be below normal, and that can be a sign that something needs to happen right away. If this isn't treated, the child can die of hypothermia, or if not hypothermia, they can have brain damage from the hypothyroidism. So the signs you're looking for, if you suspect the child has this, is the skin modeling. And I've shown you pictures of modeled skin before, but babies, this is not normal for them to have skin modeling. So it means that they're shunting blood or they're very cold. And babies are very susceptible to hypothermia. So this child would need to be warmed. So a sign would be that you can't get the child to keep a normal temperature unless they're under a warmer. You could also see an abnormally large fontanelle, the enlarged tongue, hypotonic muscles or lethargy, slow reflexes, distended abdomen, and prolonged jaundice. And this picture on the right is just what it looks like when you have extreme skin modeling. It's there's no blood flow there in the darkened area, so it can be severe. So other causes of hypothyroidism in children, an autoimmune process could have caused it. And so I want you to think of this like you would think of any of your other autoimmune disorders. What's happened is generally there's been a virus. The body has made white blood cells to attack the virus, but the body has overreacted and gotten some of your own DNA into that white blood cell. And so now the body attacks the thyroid itself in this case. So the antibodies bind to the receptor sites and decrease the production of T3 and T4. And this interferes with the thyroid's ability to produce thyroid hormone. So Hashimoto's thyroiditis is the most common autoimmune process that affects the hypothyroidism. This can also be caused, hypothyroidism can also be caused if they had to go in and resect the thyroid for some other reason. So sometimes if the baby has hyperthyroidism, the treatment could be removing the thyroid and then they would have hypothyroidism as a result. Or sometimes the thyroid's removed for an infection that may have been in the throat, and an abscess went from the throat into the thyroid, because remember, the thyroid sits right there in the throat. If you had an infection in that area, it could easily go through into the thyroid. Um, so the symptoms for hypothyroidism are the same as adults. So you would have, the signs in adults are cold, intolerance, thinning hair, dry skin, other things. But the big difference with pediatrics is that they would also have decreased growth velocity. You can add this to the list of things that cause stunted growth in kids, and also delayed bone growth. Dental age is impaired, and precocious puberty can be associated with this. The treatment is levothyroxine. I don't usually test a lot on levothyroxine, but you should know that with thyroid replacement, you're not supposed to take it the pill within 30 minutes of eating. So, and you're also not supposed to have it with calcium. So with babies, that's a kind of a problem, since their entire diet is milk. So there's a lot of calcium in it, and also when they wake up, they're hungry. It's very difficult to make a child wait 30 minutes and cry the whole time while they're starving and hungry. So you really want to teach the parents well about how to time that medication so that it doesn't occur right when the baby's hungry. That's important. Also, if the child doesn't get treated, it's important to reinforce with the parents that they have to treat this child with medication, or the outcome could be mental deficiencies. In adults, you don't see that as much because their brain is fully developed. You could see some mental fog, loss of mental acuity, but in kids, if they go untreated for their thyroid condition, they can have permanent loss of intellectual ability. Another one is hyperthyroidism or Graves' disease. This one is also an autoimmune disorder. So the immunoglobulins produced by B lymphocytes stimulate oversecretion of the thyroid hormones, resulting in the symptoms. And there's a pretty strong genetic component to this disease process. It affects 1 in 5,000 children, and girls are 5 times more likely to get it than boys. And as you think of all these different autoimmune disorders, remember that if they're on the same genetic allele, then they will be more likely to get other autoimmune diseases on the same genetic allele. So there's a high likelihood of them getting another autoimmune disease. So adherence to this particular medication regimen is poor, because you have to take the medication 3 times a day. So the child would need help with learning how to take their medication. If they're at school, a lot of times a school nurse will take care of that, but we want to teach them to be responsible for their own medications. One of the treatments is radioactive iodine. So they can put radioactive iodine in there to kill some of the thyroid gland to make it produce less thyroid hormone. And then there's anti-thyroid drugs, but the bad downside of the anti-thyroid drugs are that they can be toxic to the liver. They cause neutropenia, and they can cause you to be hypothyroid. So you treat for too much thyroid, and it's kind of hard to fine tune it. You oftentimes end up with the child being hypothyroid as a result. And then the definitive treatment really is to surgically remove the thyroid, or the part of the thyroid, and unfortunately 60 to 80% of the time you're going to remove too much, and the child will then be hypothyroid and need to be treated lifelong for hypothyroidism. So when you're doing your assessment, it's important to assess the neck for the potential of goiters. A goiter is, if you've never seen one, it looks like a giant bulge around the child's throat. And it can be either centered or it can be on either side. Sometimes if it's just one side of the goiter that's enlarging, then it'll be off to a side. Other things you might see are those enlarged eyes. The eyes may protrude and look like they're coming out of the head. That's called exophthalmos. The child might also have some behavioral manifestations like difficulty concentrating, decrease in school grades, and it can look a lot like ADD type symptoms. So anytime a kid gets, if people start saying that the child is acting like they have ADD, we want to always do a thyroid hormone check to see if this is a problem for them. And then also they're easily frustrated, they're easily fatigued, and they find it difficult to relax. In the evening, it can impair sleep. They'll have insomnia. So the treatment goals are to reduce the hormone levels or normalize the hormone levels, reduce the goiter size, and then emphasize to the family and the child when they're older that they need to be very diligent about taking the medications and not missing their medications. And then be aware that if they're taking PTU, that it causes hepatotoxicity and neutropenia. So there's considerations with that. For example, they shouldn't have Tylenol, or if they're neutropenic, they can't be around sick people that are sick. So very important. And a serious complication, life-threatening complication of Graves' disease is a thyroid storm, or also called thyrotoxicosis. And this can be life-threatening, so it needs to be recognized and acted on. They probably ought to have a med bracelet for that reason. And then symptoms of a thyroid storm are muscle weakness, sweating, tachycardia, tremors, palpitations, irritability, nervousness, anxiety. This is something that they may not recognize themselves, and you would want to be you would want to educate the family to recognize it. As far as nursing care goes, you want to promote thermoregulation. So hypothyroidism, the patient would be cold. In hyperthyroidism, they would be excessively warm. So you need to teach the family and teach the child how to dress effectively. And then nutrition. The child that's hypothyroidism may have an increased risk of obesity, whereas a hyperthyroidism child might have very high metabolic needs, and it might be difficult to keep weight on them. The body image of children with these disorders is possible to be disturbed. They could have self-esteem issues. Especially with hyperthyroidism, they can have the very prominent eyes, and that doesn't always resolve completely. They can have excessive perspiration issues and tremors. That would be something for the physician to maybe follow up on, see if they could reduce some of those symptoms. And then teach them how to have good sleep hygiene and deal with fatigue related to their hypermetabolic state. So in other words, they just have such a high metabolism, and they have such high activity that eventually they become exhausted and go the other direction. So these are important teachings to teach the family and the child how to recognize and deal with those symptoms. You can also have hyperparathyroidism or hypoparathyroidism, and I don't test on these very much, but similar to thyroid issues, they can occur where they arise from a tumor growing on the thyroid, and then the treatment would be to resect the tumor. And a primary, or in other words, idiopathic cause of hypoparathyroidism is kind of rare in kids. So just recognition is the key here. Cushing's syndrome syndrome is one that we're going to go over because it's a little bit more common. This is an excess production of glucocorticosteroid hormones in the body, or cortisol. And so that means you actually need cortisol in your body. You use it all day long, every day, to deal with, it's for dealing with stress, but a lot of times the body's exposed to stress that you don't even think about. So, for example, let's suppose that you have a test and you have some stress. Well, your body needs cortisol to deal with that stress, whereas a person or a child with Cushing syndrome wouldn't have that, and could have some problems related to not having the ability to deal with that stress. Or other things that you might not think about could be like just being cold or being hungry. All these induce stress states, and the child needs to have corticosteroids to deal with those stressful states. So a child with Cushing syndrome doesn't have that. And so the children with this disorder have to be on lifelong corticosteroids. And there's, as I've said throughout the course, that steroids impair the child's growth, and especially if you're giving it at a young age, it can impair the child's mentation. That can be something that you need to be aware of. Also, as we've said, it affects the sugar, glucose level of the child. It can also cause osteoporosis. It can cause thin skin. It can cause bruising. It can cause higher risk of getting infections or sicknesses. So it's not a great drug to be on, but in this case, the child needs it. So you want to teach the family thoroughly about this steroid. Other things that you need to be aware of course, is you have to taper the medication. So you can't just stop abruptly taking your medication. You can't miss doses, or it can be life-threatening. So these are all very important. Kids with steroids, high-dose steroids, they have mood swings. They have increased risk of fractures related to the thin bones. They have problems with linear growth, for sure. So these are all things to be aware of. In addition, and this is very important, adrenal hyperplasia can cause a failure of the body's genitals to differentiate properly in the womb. So the child can be born with ambiguous genitalia. And this picture here, I'm showing this because this is a typical example of what you might see. This is actually a female. Here, there's actually a vaginal opening there in between those labias, but it's very easy to see how this could be mistaken for a penis and scrotum. So it's very important that nurses do a thorough examination, especially if it's a newborn that they haven't seen before, to make sure that they can actually detect the gender of the child, and if not, report that, because to let this particular thing go without being treated could be life-threatening for the child. So congenital adrenal hyperplasia is caused by a defect in the enzymatic pathway, which diminishes glucocorticosteroid production and overproduction of certain androgens. Androgens are what are responsible for those sexual characteristics developing in the womb. So the increase in ACTH production increases the androgens, and the diminished mineral corticosteroid production causes salt wasting. Sodium chloride both will be wasted, but sodium's really the one that's most concerning, and this results in hypovolemia and hyperkalemia. So manifestations of this, of course, are ambiguous genitalia, short stature, hypovolemia, hyperkalemia, increased muscle mass, advanced bone age. delayed menstruation in females, premature hair, pubic hair, and excessive hairiness. So I'm going to show you in the next slide a picture of a child that has this disorder, and I'll point out some things that are important for you to remember on the test. Okay, so this child here is a 12-year-old male, but he looks 35 by his look. He definitely does not look 12. And some of the reason for that are the hairy chest, which is called hirsutism, the hairy on the legs, the jaw structure. And something else you should note is that there's linear growth retardation here. The legs are not proportional to the rest of the body. So this would be something important to note. And on the left here, we have another example of that ambiguous genitalia, the way it may have looked at birth. You cannot just rely on your visual inspection. If this is a boy or a girl, you have to spread the scrotum or labia to see if there's an opening there, to know if there's a vagina in there. Because this here, again, looks like it might be a baby boy, but it's actually a baby girl. And then as the child grows up on the right here, you can probably see that the genitals aren't fully developed on this male as a result. So diagnosis of this problem would be doing the 17-hydroxyprogesterone test, and also, so any child that has ambiguous genitalia would be worked up for this test to make sure that they don't have this disorder. And they can also run a serum electrocarbon dioxide level. Now, I don't put either of these on your test, but you should know that there's ambiguous genitalia should trigger an automatic lab workup. We'll also test for serum renin levels, low salt, and elevated potassium. And then as the child grows, we're constantly going to monitor the child's linear growth. Management of this is going to be prompt diagnosis, because some of the child in the previous picture, the 12-year-old, could have been prevented if they had been treated promptly. You need to, one of the most concerning things that could happen immediately that's life-threatening is the fluid and electrolyte imbalances. But they also need lifelong corticosteroid replacement, because, like I said, without it, they can't respond to any illness that they might get. And then they also need to have a bone maturity x-ray to assess if the epiphyseal plates have closed on the child's bones yet. The nursing considerations are going to be assessing the child's genitalia adequately. Also look for signs of dehydration. One thing to note is that if a child needs a corticosteroid replacement, sometimes they'll get what's called a stress dose. So let's suppose that they take the medication 2 or 3 times a day. But suppose they get sick, they might need an extra dose called a stress dose. Or if they have something particularly stressful going on that day, they might need a stress dose. And then also it's important to be aware that even happy events can cause stress. So, for example, a wedding is a happy event, and yet you're under more stress. So stress is just anything that's abnormal or out of the ordinary that the child, or as they grow older, need to adjust to. Education, it's important that the family knows how often they have to follow up with the doctor. So they'll check in with the child every 3 months at first to make sure that they're growing, and then every 4 to 6 months as the child gets older to make sure that the treatment's working. So there's a lot of test questions on the upcoming test on this disorder, so make sure you pay special attention when you're studying to this part. This is type 1 diabetes, which is very different than type 2 diabetes. So type 1 diabetes is more common in children. Um, Children still do get type 2 diabetes, but and as you know with your adult population, type 2 diabetes can be controlled with diet and exercise to a great extent, and it's also caused by a poor diet and sedentary lifestyle. But type 1 is not. Type 1 is caused by an autoimmune response where the um, beta cells were destroyed in the pancreas. So this child might present very differently. A type 2 diabetic will often present as being severely obese and lethargic. A type 1 diabetic might present as being thin and have normal diet and normal activity. And so it's very important because there can be some parent shaming. I've overheard a lot of times other parents shaming the parents of a child with diabetes because they'll think that it could have been prevented if the child just dieted and exercised more, which is not the case. Now, having said that, it does not help the child if they overeat. That's not helpful, or if they're sedentary. They still do need to work on the diet and exercise, but a lot of times these children are perfectly normal in their body composition and their activity levels. So the presentation is very different. You'll also see in this slide, I want you to think about especially the production of glucagon. So when you have a decreased production of insulin, you have an increase of glucagon. That's very important. And then excess glucagon leads to wasting of lean body mass, weight loss, fatigue, and then you have some other problems that go along here. The pancreas, when it fails to produce insulin, causes an increase in glucose production, increased osmolarity of the serum, and increased osmolarity of the urine. You have glucosuria, polydipsia, polyphagia, and then you have additional weight loss from that. So part of it is you have weight loss due to fluid being lost, and then you have weight loss also due to wasting of the body tissues. So both of those are important mechanisms so like I said, this child won't present as being overweight usually. You do have excessive, with chronic glucose elevations, you have an increased risk of atherosclerosis. So these children are going to have to watch their diet to prevent cardiac disease later in life because they're at a much higher risk. And then they have small vessel disease, which is narrowing of the vasculature in the smaller vessels, and this leads to diabetic neuropathy. So when you have diabetes as an adult, the average age of onset is in the 40s and 50s. The average age of onset for kids with type 1 diabetes is between 7 and 11, and these kids since they have diabetes for 20, 30 years longer than an adult would, they have a much higher incidence of some of the side effects of diabetes, like blindness, neuropathy, loss of limb is high, and kidney damage. So be aware of that. Also remember the effects that high glucose has on your vision. So high glucose causes blurry vision, and when you have decreased glucose in the brain, what are the effects of that versus high glucose in the brain? So you have adrenergic response when you have low glucose in the brain, so that causes tachycardia. You want to be able to figure out these symptoms, how one thing leads to another. For example, what causes the acetone breath that you'll see in people that are diabetic? Well, if you're burning fat and you're burning protein, then you have an increased ketones that are released in the urine and in the breath, and you have acidosis. So when you exhale, you have the acetone breath, which is what we call the fruity breath. So you want to make sure that you understand the process that leads to each of these symptoms for the tests. So peak onset, I think I said a different number in the last slide, but here it's 4 to 6 years old. And they do have the 3 Ps, so the polyuria, the polyphagia, the polydipsia. And these children don't have a period where, so when you're a type 2 diabetic, you can be on oral medication for a while before you have to go to insulin. When you have type 1 diabetes, you pretty much have to go straight to insulin. You don't have a period where you can go without insulin. Like I said, it is suspected to be a viral onset for this disease process, but it's also got a strong genetic component to it. So if you have history of anyone in the family with diabetes, you are at higher risk for having this happen. And there's no known prevention, although they are working on vaccinations, which if it's got a viral onset, that makes sense, because if you prevent the virus, then you could prevent the disease. But other treatments that are kind of exciting, what's going on right now, is stem cell transplantation into the islet area of the pancreas. And so that has been really successful, and also they've been doing pancreas transplants, which is something they've never been able to do until just recently. So that's an exciting new treatment, because this is a significant disease, and if you can actually cure it, that would be amazing. So also remember, I said that if you're at high risk for one autoimmune disorder, you're at high risk for others that are on the same genetic allele. So this particular diabetes, type 1, is also associated with Hashimoto's thyroiditis, celiac, and Graves' disease. So some key points to remember about type 1 diabetes are, 1, that it's an autoimmune disorder. So the child does need to watch their diet, and exercise helps, but it's not helpful to blame them for not having been in control of their diet or exercise and having that been the cause, because it's not. It's childhood onset. So if you have a 4 to 6 year old, one of the things is if the child's potty trained and then they suddenly start, say, wetting the bed again, this is one of the things we'll do a workup for, because if they have polyuria, that manifests as wetting the bed. So that's something that would trigger you to do a workup. Insulin dependency, as I said before, the child cannot take metformin, for example. That will not help them at all. So they're dependent on insulin. The symptoms, of course, are the 3 Ps, but you could also have some unexplained weight loss along with that. You would have altered blood sugar levels. So there's a few other things that are go associated with the onset. And then symptoms of also not taking the insulin when they should, or managing their blood sugar properly. Remember that the mnemonic: hot and dry, sugar's high, cold and clammy, need some candy. That's how I remember the treatment. Blood glucose monitoring, it's important to teach the parents how to manage the finger sticks and the insulin injections, but also as the child gets older, to have them start to take over whatever part of the care they can. So a toddler or a 3-year-old or a 4-year-old, they probably can't give themselves the shot, but they can choose which finger to get a finger stick on. But as the child gets older and they get to be, say, 7, they might be able to do their own finger sticks. So the idea is that as the child develops, they take over more and more of their own care. Kids, it's very difficult to turn every meal into a battle. When kids have type 1 diabetes, they're maybe not supposed to have, say, birthday cake. But are they going to have birthday cake? Do you want to deprive them of cake when it's their birthday? Do you want them to come to a party for a child and everyone else can have cake and they can't? That works for adults because adults understand, but it doesn't really work for kids, and they feel punished. They feel that everybody's out to get them. It hurts them, and you want meal times to be relaxing time for the family where they have good social interactions, not a time when they're fighting over trying to make the child eat the right food. And another thing to keep in mind is that so kids are going to eat what the family eats. So if you put the child on a diabetic diet, the whole family really ought to be on the diet. It's not appropriate for the child to be on a different diet than the family because they're just going to fail. It's setting them up to fail. And then, of course, the older they get, they're going to sneak food, they'll lie about food that they're eating, hide it from their family. It's really much better. What we do with kids, at least early on in their disease process, is they calculate their carbohydrates and then they calculate an insulin dose to cover the amount of carbs that they ate, rather than teaching them to cut out all the bad carbs. That's something that they can do later as they grow up and they're able to make better choices about their food. They can start learning about good carbs and bad carbs and all that kind of thing. But for smaller children, really what we try to do is just teach them how to adequately count the amount of carbs they've gotten and then give themselves the insulin based on those carbs. So that requires some math skills to make that computation, and the parents have to handle that at the beginning. So, just to reiterate, physical activity isn't the reason they got diabetes. However, physical activity is going to be an important factor in helping them manage the diabetes. So, for example, just taking a walk down the street can bring your glucose down by 10 to 20 points, right? And kids love to play. So physical activity usually isn't a problem for kids. They love to play. But as they get older, they may need to be encouraged to increase their physical activity. And then also, like I said, type 1 diabetics, sometimes activity was never a problem for them. So it's actually a bigger problem for them, say if they're doing sporting activities and they don't stop and eat, that they're more likely to have a drop in their glucose based on physical activity. So they need to be taught to always carry snacks and stop every 30 minutes or so to eat a little bit of carbohydrate if they're doing hard physical activity, like say they're in a sport. And they also have to drink that whole time. Dietary management, it's hard to get kids to eat whole grain, brown, the wheat bread. Kids don't like that kind of stuff, but you want to reinforce that as they older they get, that they start replacing those carbs with good carbs, the complex carbohydrates, more vegetables, lean proteins. Since they're at higher risk for atherosclerosis, it's going to be really important that they limit the pork and emphasize eating lean meats. Sugary drinks are not something that they should be having. So the older they get, the more we can start to reinforce that these things have to be taken out of the diet. The carbohydrate counting, like I said, the family generally has to take care of that until they're old enough to do the calculations themselves. And then you want to educate the child and the family that the consequences of not managing this are severe. Because like I said, if they have it 30 or 40 years longer than an adult, they're much more at risk for nerve damage, heart disease, vision problems. They're at much higher risk for all these things happening as they get older into their adult life. And their lifespan can be significantly shortened if they don't learn to control these things. So how do we detect these? You probably already know that we do a fasting glucose test, and so fasting glucose should be a finger stick after usually 6 to 8 hours of not eating, and their glucose should be under like 90. But if they have diabetes, it might be greater than 126. If it's over 126, then they're going to have to follow up and do another glucose test. Also, we'll do an HbA1c to see how long their glucose has been elevated. And then remember that the cutoff for kids, low glucose is under 60. But remember, for babies, it's actually lower. It's like 45 for newborns. So there is a difference there. But for most kids, we're going to go with 60. And then ketoacidosis is cut off. It starts when the glucose is over 300, but they would obviously have symptoms before that. And then teaching about all the proper pathophysiology, glucose monitoring, injections, and all of that is very important. One thing that often gets missed is that in the first year that a kid is diagnosed with diabetes type 1, they can go into this thing that's called the honeymoon phase. And it's a period of time where it seems like they're in remission. So the stress hormones are released from the hospitalization, and it sort of makes their insulin production improve for a little while. And so it can be up to a year before they have another episode. And a lot of times the parents become complacent in that 1 year period. Sometimes they even think that the child was misdiagnosed because they never have elevated glucose again. And so sometimes they'll just stop treating the child. And so it's very common for kids at this 1 year mark to be rehospitalized in ketoacidosis again. So parents need to be warned about that. It's important that they know about the child's need for snacks. So if a child has a low glucose, say in the afternoon around 4 and dinner time is until 6, the child has to have snacks, and they should be the proper snacks. So remember that an important thing is you want to have them have a protein and a long-acting carbohydrate if possible. So like peanut butter on a piece of rye bread, or a piece of cheese with a whole grain cracker, something like that. It would be a good snack. And then if they're doing any kind of sporting activities or exercise outdoors, they need to have 15 to 30 grams of carbohydrates for every 45 to 60 minutes of activity that they're doing, so that they don't have a low glucose event during that. And they have to have plenty of fluid as well. The injection sites for kids are the same as adults, but they're much smaller and there's a lot less fat tissue. So be aware. And then I've found through my personal experience that especially kids that are just brand new in their diagnosis, they're really terrified about having the injections here around their belly. So at least when they're brand new diagnosed, you would try to do something that's less traumatic for them so that they can get used to it. Now, obesity is on the rise in the pediatric population, and so there are more and more kids that are actually getting type 2 diabetes, or you can even have a situation where they had maybe a type 1 diabetes that was sort of subclinical and was never picked up, and then they get type 2 diabetes on top of it. So those situations can happen. So with both type 1 and type 2, there's some tips you can teach them. So if they're not having trouble getting blood into the finger stick area, you can put it under warm water. That'll draw blood to the area. The ring finger is preferred because it has more blood flow. So teach them to use the ring finger. Also, you want to teach them to do the finger stick on the side of the pad because it causes less pain later. You would want to teach them to use the lancets that are small and you draw the least amount of blood because they have the lancets in the hospital, they go very deep. Actually, it's way more deep than what's necessary, and so we can teach them to use the type of lancets that don't go as deep, to protect the kids' little fingers. Also, EMLA cream can be applied, especially early on when the child is newly diagnosed, until they get used to having all those finger sticks. And then also teach them what to do if the child has a low glucose episode. So if the child becomes unconscious, a lot of times we'll teach parents to carry something in mom's purse, like a glucose paste that they can put around the gums, and the child can actually absorb some of that glucose through the skin buccally, and you would do that every 5 to 15 minutes, and then take the glucose, and then of course call 911 if the child doesn't improve in 15 minutes. But but of course, you want to teach parents how to avoid having to have the child go to the hospital. So that early intervention with a glucose paste can help them avoid the hospital altogether. And then parents can also carry glucagon shots to help with low glucose. And then, of course, if we're in the hospital setting, we'll give D50 dextrose in a shot immediately, preferably intravenously, to try to reverse that low glucose. Of course, being sick is stressful on the body, and the body releases cortisol when you're sick. So kids that have type 1 or type 2 diabetes tend to have higher blood sugars when they're sick, just like adults do. And so children always have to have the insulin. Your question might be like, they're sick and they're not eating, why do they need insulin? Because you're supposed to eat if you're taking insulin. So the answer to that is that their glucose is elevated because of the stress hormones alone with being sick. If you give the insulin and they're still having low glucose issues, you can always give 7-Up. Most kids can keep 7-Up down even when they're sick, but otherwise you would call the doctor. And then even when they're sick, you want to test the glucose every 4 hours. Even if they didn't eat. So another thing is you can check the urine for ketones in the urine, although that's a late sign. If there's enough sugar to get into the urine, it's kind of late. Increase fluid intake if there's ketones in the urine, because that'll help clear ketones faster, encourage the child to rest, and teach the family when to call the doctor, especially if there's fruity odor to the breath and it's not being relieved by 7-Up or whatever. If they develop rapid respirations, confusion, changing level of consciousness, or persistent hypoglycemia or hyperglycemia. One of the harder things to determine is what is a child capable of doing as far as them caring for themselves when they have a diagnosis like diabetes. So toddlers can participate in some of the self-care, and like I said earlier, they can pick which finger gets to be stuck, but they're always going to look to the parent to see if the parent is paying attention. So that means they're going to test the limits. That means they might try to sneak food off of someone's plate, or so the parent has to be vigilant, especially if a child gets diagnosed this young. Especially a thing that happens in the toddler years is when toddlers throw temper tantrums, and a temper tantrum can look, it can be normal, and it can be abnormal. Temper tantrum can actually be a low glucose episode, because as you know, low glucose causes irritability. So you want to teach the parents to recognize if the child's having a low glucose episode as opposed to a temper tantrum. When kids are a little bit older and they start to go to preschool, they can understand rules a little bit better, and they're a little bit less likely to test the limits at this point. Their eating behavior is a little bit more erratic at this period, so it can be hard to get them to eat at the exact right time that you want them to eat. But they're also capable of performing a little bit more of their own self care. They might be able to do their own finger sticks at this point. So, and they're very energetic at this stage, so they can have low glucose episodes. So be aware of each age group and their particular challenges that they might have. A preschool child, a lot of times, is old enough for us to give Care Bear. They have these little teddy bears that have diabetes, and they treat the diabetes buddy. They call him a diabetes buddy. They treat they imitate the parent treating the diabetes. So whatever is done to them, they do to the teddy bear, and that can make it a lot easier for them to transition into doing their own care because they've practiced on the teddy bear. School-age children tend to really be afraid of being different than all their friends, and so they really want to not look different. They'll hide from their friends that they have diabetes, and sometimes that's especially dangerous if they're like on a sleepover or they don't have the ability to get away and go get their shot from the school nurse or whatever. So this is a very important time to be vigilant in watching them. But at this age, they can perform a lot of their own self-care. School-age kids start to learn math, so they can do the carb calculation. They still have to be double-checked by the parent for accuracy, but they can do the calculation. And they may even be able to start maybe drawing up their insulin, and as they get older, giving themselves the shot as they progress. And they start to make independent decisions at this age, especially when they're at school and the parent's not there. So it's important to teach them to not eat out of the vending machine, for example, or if they're at a friend's, to not overindulge in whatever foods that everyone else is having. In your early adolescent age group, they're having growth spurts, and so corresponding with some growth spurts, they could also have episodes of low glucose. The glucose can become erratic at this point because it's hard to calculate what the body's calorie needs are. And they're more and more concerned about their body image. They're influenced by peer pressure more, and they want to challenge authority in this age group. So, and also at this age group, the child's capable of understanding abstract ideas. For example, diabetic neuropathy would be an example of something that's pretty abstract because you can't see it, you can't look at neuropathy. It's something you have to just read. You can read about it, and the child can learn that way. But it's a completely abstract thought. So at this age is the first time when you can really start to educate the child about some of the things that could happen if they don't control their diabetes, such as neuropathy, blindness, things like that. It doesn't mean that they'll believe it'll happen to them, because one thing we know about adolescents is that they never think any of those things will happen to them. But at least they can start to understand the concepts of what it is. Another thing that we worry about is with this age group, sometimes girls especially learn that if you take a little bit less insulin than you're supposed to, you you end up dropping weight. And so sometimes they abuse their disease process. They abuse their bodies by not taking enough insulin deliberately. And this can lead to some severe problems, of course. And they do it because they find out that when they do that, they tend to drop a little bit of weight. And it's not safe. It's a form of anorexia. And we need to teach them that if they're dropping weight and we're suspicious, we need to follow that up. Of course, once they're getting to the later stages of adolescence, they're even more at risk of abusing that process with the insulin, because they don't think that any of the negative bad side effects are going to happen to them. But also in this age group, they're thinking about doing things like smoking and drinking. And as I was saying earlier, they're at double or triple the risk of anybody else for having problems with their heart. So they should never smoke, and they should probably never drink. But if they do drink, they should not binge drink ever. And then one thing that doesn't get taught a lot, and they really should, is that most of the girls know that you're at a higher risk for blood clots when you take oral contraceptives. If you're diabetic, that risk doubles or triples. So it's recommended that adolescent girls don't take oral contraceptives, that they use another kind of birth control to prevent them from having some of those long-term complications. And those are kind of some hard sells when you're trying to teach an adolescent girl what to do, right? But boys, definitely also keep them, you want to teach them to avoid alcohol and smoking. Avoid any risk-taking behaviors. Teach them that it can happen to them. And then teach them it's especially important not to just do what their friends are doing. This slide in here so that you could see a sample of what you could try feeding the child when they're sick, because as you know, you give the child the insulin even though that they're sick. They may or may not eat, and it's hard for them to keep food down. So what can you give them that's enough sugar but not too much? Like crackers are good, a cup of soup is good. You can give them watered down sports drinks. Remember, I have said this since the beginning that Gatorade and those commercially prepared sports drinks are too much sugar, but you can give them like a half watered down version of it. You can give them juice or soda, but it should be watered down also. Mashed potatoes, things of that nature. So with type 1 and type 2 diabetes, of course, you already know probably that retinopathy, neuropathy, nephropathy, cardiovascular disease are all much higher risk. So this is a case where we really have to prepare them for what their adult life is going to be if they don't control their illness. To prevent all those things. Eye exams, they have to get them every year. And it's real important that kids get immunizations when they're diabetic to prevent illness, because any kind of illness can cause them to be more susceptible to problems. Of course, I put this slide on here so you could kind of remember the difference between the treatment for hypoglycemia, hyperglycemia, and ketoacidosis. So with ketoacidosis, things you want to think about, they're going to, first of all, if they have high glucose, you're going to have to assume that they're dehydrated, because the glucose has a different osmotic pressure, and it pulls fluid with it out of the kidneys and out into the urine. So they're dehydrated, so they need a fluid bolus. Also, because they had ketoacidosis, they're acidotic, so a fluid bolus will help kind of clear that the ketones faster. But in addition to that, you may have to give bicarb to deal with the acidosis. Also, when you pee a lot, you're going to lose potassium. So the next on the list of priorities is replacing the potassium. Now, if you're giving a potassium containing fluid to a patient, the biggest thing to remember about that, and this is on the test, is that you can't give a potassium containing fluid to a child until you know if they can pee or not. So they'll generally get a regular fluid first, and then they'll get the potassium after they've peed. Then the next thing is they'll probably get an insulin drip. So you'll give regular insulin by IV, maybe 1 unit an hour or whatever. They'll base that on their blood glucose level. But you don't want to drop the blood sugar too fast, because that can cause some problems all by itself. So they're going to run some high glucose levels for at least 2 or 3 days, while they're slowly bringing the glucose level down. And then they're going to need support. So in the initial period, also, they might have needed oxygen, and they might be a little bit neurologically delayed, or impaired while they're recovering in the early times. They might be sluggish, confused, but it gets better as the glucose levels come down and the acid starts to clear out of their system. So then you're going to be focusing on teaching them about how to manage their diabetes better, to prevent that from happening again. Whatever brought it on, teach them how to avoid that again. And I include this slide, don't try to memorize this, but just take a look at it, because it gives you an idea. Generally, we have this in the hospital, and you just follow this algorithm, and this is how they decide what to do next. So it's just like any other kind of cardiac algorithm, but this is for diabetes, and it tells them what they're going to do next based on the insulin level. So you would just, it takes a lot of the stress out if you know that you're just going to be following an algorithm. And of course, I'm not going to spend very much time on type 2 diabetes, because you should already know all of these kind of interventions, but just remind yourself of them for testing purposes. And remember, so if you have hypoglycemia, remember that the signs are trembling, sweating, tachycardia, clammy skin. So like I said earlier, the mnemonic is cold and clammy, need some candy. If you're hyperglycemic, you have the 3 Ps. You have fatigue, weight loss, blurred vision, and remember the mnemonic, hot and dry, sugars high. And then if it's over 300, it crosses over from being just hyperglycemic into ketoacidosis. So remind yourself of the signs and symptoms of ketoacidosis. So you would have excessive thirst, excessive urination, fruity breath, nausea, vomiting, abdominal pain, Kusumal breathing, fatigue, weakness, confusion, and high ketone levels in the urine. And I included this slide so you can look at this on your own, but it's a lot of people wonder, why aren't all the kids on an insulin pump? And so just so you know, if you read through this, you'll get the idea that basically not everybody's a great candidate for being on an insulin pump. It depends on how well controlled they are, and so you can look through this. None of it's going to be on the test though, but just so you know. So in general, some signs that we maybe didn't talk about enough yet, other signs of gonadal dysfunction. Gynecomastia is common in boys when they have excessive estrogen or not enough testosterone. In females, you could have amenorrhea or dysmenorrhea. Earlier in the slide presentation, I talked about that heel stick test that they do at birth before the child goes home. And this is to check for 50 different, or maybe it's more than 50 now, of metabolic disorders that they can test for. So this is just to let you know what it looks like. In the lady's hand, there is the baby's foot, and she's squeezing the drop of blood out of the baby's foot onto the paper, and there's 4 little circles, and they're what you have to do is fill up the white circle with the blood, and they don't want you to overfill or underfill it. They're pretty particular about you filling it just right. So PKU, the thing you need to know about that is it's an error in the fatty acid oxidation. So the reason this causes catastrophic problems for the child's mentation is that if you don't properly metabolize fatty acids, which are in everything that you eat. So the baby would be getting fatty acids in the mother's breast milk. If they don't metabolize that properly, that those that builds up in the brain. And so as it builds up in the brain, that's what causes the catastrophic brain damage to occur, and it's irreversible. So a lot of times parents will ask, why do they have to have the child take this test? Why is it required? And your answer would be because by the time kids show these symptoms that they have this disease, it's way too late. The damage is already permanent. And now, besides just testing for PKU, they also test for things like maple syrup urine disease, which is rare, but again, if they don't catch it early, again, it has catastrophic consequences. And so it's required by law because they view it as the parent making a decision for the child, that the child doesn't have any say in whether they get it or not, but they assume that the child certainly would have wanted to have had it prevented if possible. So remember that when you're talking to the parent about why it's necessary. And in general, remember that overall the signs of an endocrine disorder, if you don't know what you're dealing with, but you suspect some kind of endocrine disorder, you're going to see changes in growth rate, maybe changes in cognitive development, or changes in sexual development or metabolic regulation. So these are all important signs of an underlying endocrine disorder. Remind yourself also of some of these different disorders that can cause growth, delayed growth or stunted growth. So there's at least one test question where you're asked to pick some of these off of a list. And then once you've identified a child with a metabolic disorder, your nursing responsibilities after treatment are to make sure that the family understands the diet management, symptom management, recognizing decline in health, medication management, teaching about the dangers associated with having this disorder, and long-term management of the disease process. Alrighty, thanks.